Hello and welcome to today's UCL Global Business School for Health, Global Healthcare Management, Finance, Roots Taster Lecture. My name is Lauren and I'm part of the Marketing Communications team for the UCL Global Business School for Health. Today's lecture will give you a taste of what to expect if you choose to study a Masters in Global Healthcare Management Finance, a GBSH, and to help you gain an insight into what it's really like to study on this programme. The session is being recorded and will be shared via email following today's event. Now to introduce our speaker, I'm delighted to welcome Dr. Rama Prasad Kanungo, Associate Professor in Finance and Accounting and Route Lead for the Global Healthcare Management Finance Route at the Global Business School for Health, who will be giving today's lecture. Following that, there'll be a Q&A session. There's a Q&A box at the bottom of the Zoom screen. Please type in any questions that you might have throughout the lecture, and Rama can answer them at the end. And with that, I will hand over to lecture. Over to you, Rama.
Thank you, Lauren, and welcome, guys, to our online taster lecture session. What I want to begin, I want to tell you how we deliver teaching in GBSH. In this program, we follow an approach called a flipped classroom approach. In there, what we do, we record a video and upload on the Moodle, which is a virtual learning environment. So you can watch in your time. Then following week, in light of what we have recorded, there will be a classroom in-person presentation from us to you. So it includes the presentation, discussion, then we interact with quiz, statistical analysis, quantitative modeling, depending how the class is structured. So what I'm going to do today, I'm just giving an overview, a flavor of what is likely to be in classroom with us in global healthcare management finance route. I will be leading a route, but at the same time, I will be delivering one module, which is called risk management in healthcare, which will be in from October to December. That module I'll be covering. So, but today's taster lecture is based on health financing. So for that, what I will do, I will share my screen and go through the slides. Okay, here we are. Can you see my screen?
Yes, I can see it.
Okay, guys. So I welcome you to Healthcare Management MSc Finance program. I will see you all in September during our induction and subsequently in classroom. Then what we doing today, we focusing on health financing, which is a very critical element of health, finance, and economics related topic. It's very interesting, and it's a kind of critical to learn how it impacts the overall healthcare system, public health, population health, ideally health financing related to public health. So what is health financing? So we are going to cover around 6 topics, 8 topics, and through different slides. And then, like Lauren said, you have your time to ask me the question at the end of the presentation. So the ideal thing, the money is the language of business. Money is the language of healthcare. Money is everything. Without money, the system where we survive is society, social system, welfare system, health system, technology, whatever, share market, trade market. It's all surrounds the simple idea money runs all these things. But the most important part we at Global Business School for Health focus on is the implication it links to the health. So what the World Health Organization defines the health financing, it has 4 constructs: prevention, promotion, treatment, and rehabilitation. When money comes in, just imagine money comes in forced construct, and it joins together and it turns into health financing. This is the whole idea behind this. So money should bring up prevention, disease, sickness, and it should promote good health, equitable health. It should provide access to treatment, and it should provide us to rehabilitate if we need more support in terms of our health and welfare. Health is not just about physical health here. We could talk about mental health, we could talk about environmental health, we could talk about welfare in general. When we'll go through the risk management module, you can see the risk. We're not talking about one kind of risk. We're talking about everything, technology to clinical to trial to drug treatment. So it's a combination of things. So what is most important factors? What are the most important factors contributing to health financing? So we have to ensure it is accessible. Around 23% people in emerging low and middle income countries do not have access to primary health care, forget secondary health care. Because we always see all these emerging countries, for example, in India, Argentina, Brazil, Bangladesh, Pakistan, Sri Lanka, what happens in there? We always discuss about cities, big towns. We don't discuss about peripheral people having in poverty. They are not within the mainstream financial inclusion. I have recent research on that, how financial inclusion could promote well-being. One is published in last year. One is going to publish. We have some real data in classroom. I will share that with you. So they are not having the accessibility. The quality of care is not that as they should be receiving, and they do not have sustainable healthcare provisions. So combinedly, they suffer. So if you look at that healthcare spending, it's a hyperlink. It's taken from our World Health, our data in world. It's a data center by Oxford University, supported by Harvard University Medical School data feed. So if you click on that, you can have these slides after our presentation. So you can go to the hyperlink and read more. So the simple idea behind the universal health care. So what we say in technical term, it's universal health care, providing health for everyone, providing finance for everyone, providing access for everyone. So the first thing is we have to create the funding for the resources. So for that, we raise the revenue. Revenue is internal when you doing a business, your hospitals are running, healthcare centers are running, pharmaceutical companies are running. Then the next phase comes as pooling. Pooling means you put multiple funds, multiple resources together to optimize or leverage the benefit. The other one is purchasing. You can purchase extra funding through different ways. We'll see that details in classroom. Hopefully all of you will be there. So it depends on four things. Stewardship means how carefully you are accountable and managing that. What kind of governance structure you have. What is the structure to maintain those things? And what kind of oversight are kept on this, and who is maintaining to do that? So we have a short-term or intermediate goal for universal health coverage. What we're doing now, we're still staying with health financing. Okay, so what we're trying to say, to achieve these four elements should be prevention, treatment, rehabilitation, and access, support. We need this. So the funding should be equally distributed. I don't know how much you know about UK healthcare system. NHS, most of the funding go to the different units called ICBs, and they distribute the fund. And it's asymmetric. Asymmetric means some funding people, some centers receive more, some people less receive less. Although it's based on priorities decided by people depending on who needs what, but it's not always equitable. Then efficient, how effectively things are managed, provided, and sustained. That is a key challenge efficiency is a key challenge in NHS. If we reduce our efficiency by study by 2%, there would be $1.8 billion loss in traditional NHS healthcare trust. That means if things are delayed, there is a link on the slides coming. That check this. It is done on a lot of countries. I will tell you when we go to that slide, and it will tell you the percentage change. The reason I'm focusing on percentage change, as finance students, you should be very attentive to numbers and be able to explain how numbers are playing. What is the interplay between Rama is saying, okay, 2% reduction in efficiency. What do you mean by efficiency? So for example, the 2% delayed of time providing a drug to a patient. So in 1 year, a drug should come. 2% of 1 year is, say 2 weeks, 3 weeks. If there is a 3 or 2 weeks delay, a cancer patient could die. The people having critical health condition could die. So how important is finance to maintain that efficiency? Then it should be transparent and accountable. So there should not be rent seeking, corruption should not be unclear because these funds are public funds. That means this comes from our salary. When we give salary, we give something here called NI, National Insurance. Within that, 9.1% goes for healthcare. So in UK, we don't pay money for private treatment. You can do that if you have money, but mostly you get that through government NHS, National Health Services. It started in 1948. It's a welfare system set up and universal health coverage it does. And so the money comes from public. So what we pay, there is a tax NI, National Insurance. Out of that, 9.1% goes to NHS. So the final coverage goal is to utilize our need versus the cost, the financial protection and sustainability, resilience, and equality in financial distribution, funding distribution. And it's not about that only giving you money, but at the same time, the quality. So it should be the combination of all these things. So I will go quickly through this slide. The government spending, you can see from 1880 to 2023 is a long 100 years data. It's taken from OECD expenditure financing data by 2024. It built on 1993 OECD data and Lindet data 1994. So it's the percentage of your GDP they're spending for healthcare. You can see most of the Western European countries like Germany, France, UK are there. Then Sweden, Japan, Australia. If you expand that, you can easily go to this source and see all the distribution. You can download the even Excel spreadsheet if you want to see who is doing what. Ideally, the countries provide higher GDP for healthcare are having a robust and stronger healthcare system. But remember, in UK, it has been challenged because it's quite a large structure, monolithic, and there are multiple issues within that. We don't have to, but they're doing a fantastic job so far, so good. But they always need to improve. The same idea we tell you, or anyone tells us, yeah, we're doing okay, but we need to improve. It's the same thing with healthcare and their financing. Then this is a short video I want you to watch. This guy is from MIT, is a professor in finance. He was skeptical that money or finance is important in healthcare, but his mother got cancer, and what he did, he talked to healthcare people, those are developing drugs, new drugs for cancer. It's about his course. He runs a course in health financing. I won't run the entire video. I will run, it's 6 minutes. I'll run until 4 or 5 minutes. When you'll have the slides, you can watch yourself. Let's play this and you can
We
watch
do this
it.
all the time in other industries. Hi, my name is Andrew Lowe, and I want to welcome you to 15482 Healthcare Finance. Now, you might be wondering, exactly what is healthcare finance? So let me start by telling you a personal story. A few years ago, a number of friends and my mother were dealing with various kinds of cancer, and in my mother's case, the standard treatments weren't working. So a friend of a friend introduced me to a very successful biotech company that was developing a number of new cancer drugs, including one that might help her. I was privileged to meet with the chief scientific officer of the company, who brought along his chief financial officer because I guess he was told that I was a finance professor and he thought he might need a translator. During the course of our meeting, I asked what I thought was an innocent question. I asked them whether their sources of financing had any influence on their scientific agenda. As you can imagine, I was very interested in how they prioritize their agenda, since one of the projects was related to the kind of cancer my mother was battling. I'll never forget his answer to my question. The chief scientific officer shook his head, looked at his CFO ironically, and then turned back to me and said, "Influence? Our financing drives our scientific agenda." Now, I'm an economist, so I do get it. You have to pay for stuff. But as the son of a dying cancer patient, I was absolutely shocked and outraged. What do interest rates, stock market volatility, and Fed policy have to do with whether you should treat cancer via angiogenesis inhibitors, immunotherapy, or radiation? Nothing. And yet it drives their scientific agenda. Now, I'm no biomedical expert by any means, but should the science be driving the financing instead of the other way around? Well, that's what this course is about. That incident convinced me that finance actually plays a huge role in healthcare, particularly in the drug development process. One of the things that I learned early on is that this process suffers from a triple whammy of challenges. Number one, it takes a long time to develop a successful cancer drug, in some cases 10 to 15 years. Two, it costs a huge amount of money, on the order of hundreds of millions to billions of dollars per drug. And three, the chances of failure are extremely high, especially in oncology. This trifecta of challenges means that investors aren't going to be as keen to invest their capital in this process, especially when there are more attractive investment opportunities in other industries. But here's where healthcare finance comes in. What if we use the tools of modern financial engineering to reduce the risk and increase the rewards of biomedical investing? We do this all the time in other industries and contexts. For example, if you have any kind of savings or retirement account, you're probably holding some of your assets in an index fund, which is a portfolio that contains literally hundreds of stocks, like those in the S&P 500. If you do invest in such a fund, congratulations. You've taken advantage of one of the most basic and important ideas of modern finance: diversifying your investments across a large number of stocks instead of trying to pick one or two winners. Well, the same approach can be applied to drug development projects on a massive scale, and the same kind of financial benefits should emerge. And if we use all the other tricks of the financial trade, portfolio optimization, collateralized debt obligations, credit default swaps, and derivative securities, we can attract much larger amounts of funding to develop the miracle drugs that desperate patients are waiting for. Now, you might be scratching your head right now and wondering, really? Is this really wise? After all, didn't these tools figure prominently in the financial crisis of 2008? Well, I have to tell you that it was studying the financial crisis that started my thinking along these lines. The financial crisis didn't happen because these tools didn't work. It happened because these tools worked way too well, channeling tremendous amounts of money in a relatively short period of time into US residential real estate. In fact, Warren Buffett called some of these tools financial weapons of mass destruction. And he had a point. There's tremendous power locked up in global capital markets. And when that power is unleashed carelessly and irresponsibly, financial engineering can cause great devastation and disruption, with fallout that can linger for years. But the analogy cuts both ways. When powerful tools are used carefully and responsibly, financial engineering can provide virtually unlimited resources to fuel innovation and economic growth for generations to come. The more you know about finance, the greater the chances are that you'll be able to use these techniques properly, responsibly, effectively, and ethically. That's why my colleagues and I at MIT.
Okay, guys, the reason I stopped here because he's going to talk about his program, course he developed. But the summary is very thought-provoking in this video, is that the health financing as such as in general finance we have seen in traditional business school that subject has tremendous potential to interact with the healthcare sector. Healthcare sector is not about hospitals, primary cares. It could be pharmaceutical companies, it could be biotech companies, and it could be technology company driving artificial intelligence or machine learning or high trading data or option pricing into financial market. Those are indirectly related to the healthcare, drug development, drug trial, population studies, global health limitations in many low and middle income countries. Those can be applied to multiple contexts and multiple environment. For example, you might know Bill Gates have large programs under Bill and Melinda Gates Foundation, Bill Gates Foundation for malaria in low and middle income countries. He has spent 180 millions for changing malaria in Latin American countries, in Southeast Asian countries. So what I'm trying to tell you is here in light of this video is that the finance is a critical knowledge which is very important to impart you that skill, this understanding and critical thinking, how that could interlink, interplay with the healthcare system, health industry, or welfare system in general, in wider circle, will be helpful. So in our program, we have four health related, finance related modules. One is mine, risk management. There will be another one, accounting and finance. Those about reading the financial statement, critically interpretation of those statements, and making meaningful derivation from the financial statements. The other one is capital market and equity, how the capital market works, so how the funds run through that, what is the movement of shares and equity, and how we'll capture that. The other one is the economic valuation, health valuation, how you look into the valuation of the investment in terms of output. So these are very critical elements to health financing. So where that money comes from, one is government funding through taxes, social health insurance. The other one, the private insurance. Ideally, it's twofold: is government and insurance. The other one is out-of-pocket payments. If you look into World Health Organization or World Bank data, International Monetary Fund data, they have a database, it's public. You can look that. Most of the countries around still 63, around 60 to 65% people are out of pocket payment, means they pay the money from their pocket. There is no universal health coverage. So what happens with that? Remember the slide 1 and 2. It will contradict what I just said on the slide 1. It's not equitable. It's not accessible. It's not given to people suffering. It's asymmetric, distributed, fragmented, unequal. The health equity is not properly tuned to the funding. So who should know this? You guys should know this because you are the future thinkers in terms of decision makers. If you work in companies, you have your industry or your business. What do? You take that critical decision, timely decision, time stamped actually. Okay, we've taken the decision in June 2025, which will be going to impact in 1 year time. So we'll reduce the private insurance percentage and increase how we could have public government funded public funds. So that there are very minor marginal element of finance in health, which is from international aid and donations, like World Health Organization, IMF, blah blah blah. So to keep the time in view, so we have another 20 minutes, I think. So let's look at the health financing models. What are the financing models? The ideal model is Bismarck. It's a German model. During Bismarck, it was developed. It's basically insurance-based, an employer and employee's contribution, whereas employees will pay less and employer pays more. Like same system, we have pension system in UK. The other one is Beveridge model, which is a tax-funded national health service. It's a UK model developed by those people. Click on the link; it will take you to the paper, an article. Is the UK's funding healthcare system is tax-funded national health services. That is why we call NHS. The other one is a Moscow model. That's an Russian model. It's similar to the single-payer healthcare system. So you pay one off, and it carries on throughout your life term. Then the national health insurance model is they combine two types. And the worst one, the most people go through that is the out-of-pocket model. So no universal coverage, it ad hoc, as come, as served. That means if you have a health problem, you go to see the doctor, pay him, and then go to hospital kind of stuff. These are ideally for different types of models. So what are the models? Why should you study model? You will ask me. The reason is models is kind of our theories and concepts are put together. So we call them conceptualization or theorization. To understand the finance, we first have to understand the theory. So theorization plays a very significant role in terms of understanding the models. Models is not actually always numbers, okay? Models could be a framework. Model could be a conceptual framework put into different symbols, different numbers, different pictures. So there are different ways of interpreting the models. So these are the frameworks for public health financing. So the other one, we have to see what are the quantitative ways, the numbers, because you're a finance guy, your brain is ticking in terms of numbers. Where is numbers? We have not seen the numbers now. We are going to see now. One is called actuarial model. Most of the insurance people called actuarial people, they use the cash flow and use different inputs they receive through the the market indicators to decide what should the insurance premium for the healthcare people. The other one is the cost effectiveness analysis that we run in our valuation module. Actuarial model I will touch in risk. A simulation model I will show you in risk as well. It's not actually a simulation model, but a predictive model called Cox proportion hazard risk model. I will show you that with real data, and we'll go through that step by step. We'll do that instead. So actuarial model, they take the cash flow, take different variables and input them and run it. Then cost effectiveness is for unit cost, what is the output and benefit? There is a ratio of that. You could do a little bit of more advanced analysis in there, taking the derivatives or partial derivatives. The simulation model is ideally based on multiple models. There are a lot of simulation which the real data can be used. Synthetic data could be used, but you simulate the model instead of running the real model to see how it works. But that's not important. We don't have to bother. Now we are in the time of artificial intelligence and finance. We have a module in running this year called artificial intelligence and finance that will run in term 2. If it's an optional module, you can take that. That two optional modules, one is AI and finance, the other one is called capital market and equity. Either one you can take as your optional. So, okay, coming back to predicting the financial impact. So what do? You look at the cost effective, we look into the different models. Ideally nowadays, what we're doing, we're using artificial intelligence, machine learning, or high volume data. So I did also study on that using artificial intelligence to see how cognitive artificial intelligence works. There are 4 types of artificial intelligence. One is generative, like your ChatGPT, and then the predictive, they tell you the health, diagnosis, and prognosis. Then the other one is called analytics, which is more advanced than combination of generative and predictive. The most advanced is similar to human brain, is called cognitive. The 4th generation kind things. It has only it's not verified, but there is a Chinese company. They have something like that advanced apps, but it's not yet full finalized. So the other model you can use is regression, which is a very traditional finance and economics model, where one will be predictor and others will be independent. One is a dependent variable. Y is equal to alpha plus alpha 1, x1, x2, x3, x4. So this model will tell you basically how different variables interact with one thing. For example, you're taking a drug, so the duration of drug, the efficiency of drug, and other things you can put in the model and see what is the quality of your drug, what is the efficiency of your drug. But remember, regression model is a generic term. Under regression model comes around 20 different models. So for example, you can have a simple or multiple regression. 2, you have binomial, multinomials, probit, tobit, forest. multiple different kind of regression, but you have to decide what are the assumptions, how it applies. As finance students, you should know this, and it's very effective in your future career. Okay, so out of expenditure, I told you, this is just a illustration. Lighter tones are people less using out-of-pocket expenditure. Darker tones, people using more and more out-of-pocket. But in average, this is the latest data by World Health Organization in 2025. Okay, so what are the challenges in healthcare financing? Rising healthcare cost, inequalities in equity, financial sustainability, balancing public and private sector involvement. So there should be a relationship. They work together. And so when they work together, the benefits are more. So universal health coverage is 4 things: improve public health, prevent financial hardship, boost economic growth, reduce inequalities, which we have kind of touched. So this is all about how we can achieve a system where health is for everyone and how money can support that. So the funding mechanism, examples of countries done the successful way, like Sweden, Thailand, Brazil, Costa Rica, South Korea. I think Brazil used a system called Sentinel during COVID. That was used in South Africa in 1990s, and Brazil borrowed that idea and tried to use that in during COVID, and they reduced that mortality rate around 10 to 12%. I have a paper on this. One paper we have published, one paper we have is under review with another journal. So the Sentinel system is quite effective, contrary to other countries like India. We had 10 or 12 countries, the most affected countries during COVID. So India, Brazil, Argentina, Bangladesh, I think Pakistan, and we have also taken USA, France, UK, Sweden or Denmark, I can't remember. So 10, 12 countries. So we have a comparative view how it works. Among all other countries, Brazil's, the death that the COVID that translates to death, that means number of people got COVID and going to die, is least in COVID. Do that make sense? I'll explain that. I mean, say 10 people got COVID. How many people dying with that? 2, 6, 10, or 8? One, if you can get COVID, but if only one person dies, that's good. So COVID, the technique they use, the model, the Sentinel system in Brazil, they showed that the number of people getting affected, the least number of people are dying. So what we say that, in technically, the the infection to morbidity. So we created a measure for that, infection to morbidity or mortality, you can say that. So that is a list in Brazil. So these are the countries that have used a very successful universal health coverage. And then the role I told you, it's not an individual role, it's a collective. It comes in social welfare and for everyone: insurance companies, pharmaceutical companies, medical device manufacturing, pharmaceutical companies, biotech companies, public and private entities. So there's multiple things. This is a short video. It's a company they're promoting there, but they talking about the digital side of that, which I was referring briefly. We if you are from a city, you ideally think, okay, it's all about cards payment, this, but in reality still around half of the world population are not used to digital payment. Some places they have digital payment, but they're not working efficiently and effective. Some places they do. So it's not very consistent and across the different segments of society or people or patients. So what were we doing? If we have a digitalized process where digitalization will advance the payment gateways, that means through which you make the payment, digital payment gateways. So I have another paper as well, actually. It is published. I'll show you in classroom, or you can, the key points I can discuss with you, so I can share my direct experience. So digital payment, for example, we did study in UK, US, India. So what happens there? We looked into different constructs: the distance of bank to people's house, number of ATMs, in that locality per 10,000 people. Then we wanted to see the correspondence, the business correspondence banks have for digital payment for healthcare workers. It's a lot of different elements. We looked into that. So what we concluded that it's not equally distributed, which is intuitive, means anyone can say. The most important thing we found that they hesitate not to necessarily learn how it works, irrespective of how serious the health issue is. They always want someone who they can know personally and directly confer with them. They call them BC, business correspondents. Those people are known, say you are a village, they know this person and 5 villages, they feel more comfortable to going to that person to discuss the payment system, payment things, than directly going to hospital and making a payment to the payment machine or digital gateway. Okay, so these kind of things, this is our a little video. You can watch in your time. The reason I want to move on, so I want all of you, I don't know how many of you are there, all of you, can you please scan this code, a QR code, and we are going to, I will stop sharing, no, scan it, then we'll do a little short quiz on your finance module, the health finance chart. Menti link is there as well. Lauren has put there. Thank you, Lauren. Can we please go to this one? So I will stop sharing. Have you all taken the photo of this? Also, you have the link. So what I will do, I will go now to a Menti and I have only 4 responses. I don't know how many of you are there. You are 8 of you there. Okay. So the healthcare financing is quality and maintaining financial sustainability. So the next one, please. What is the direct cost in healthcare? You can see your results after this. I will share the screen and you can see the results. If you have studied finance, there is 2 types of cost. One is a direct cost, one is indirect cost. Correct? The train running, there is no patient in hospital, still there is a cost. And there are patients coming, then it's becoming a additional cost. Okay, indirect cost. Okay, 2 out of 2 from 8. Anyone, guys? Four. Okay, good. Then next question, capital budgeting. Don't worry, capital budgeting, if you have not done this, you might find this difficult. So, okay, let's try this question, which is an easier question. What is the key reason for the rise in healthcare cost? We just did that in a slide. One more, only 1 out of 9, 2. Don't worry, you will see your answers. Don't worry, there's nothing to worry. It's not like an exam. Even if in an exam, you don't have to worry. Well, we have a different viewer, which is good. In classroom, we'll do that if you have different views, and the answers could be anything. But in this case, there is one answer. But say we are doing a case study or seminar or group discussion or presentation or a symposium, something like that. We can all discuss and see how we view that. Then, guys, the next one. What of instant provision? Okay, you know that I would not necessarily cover that. Yeah, this we have not covered that. But what comes to your mind? What is the common method used by healthcare companies or organizations to control cost? Increasing staff, reducing outsourcing, expanding services, offering more insurance options. What do you think, guys? Give it a try. It's nothing to worry. Two. Few more. One more, expanding service lines. Yeah, okay. Are you sure no one going to answer this one? Oh yeah, one more. Two, good. Anyone else? Okay. Oh no, that's difficult. We have to cover that. Okay, what comes to your mind of this, which is not typically considered a source of healthcare revenue? Insurance reimbursement, donation and grants, pharmaceutical sales, investment in external companies. It's quite obvious, isn't it? It means this is a very intuitive question, but try this one. Let's see. Okay, just one answer. More, please. Few more until I move to the next one. One or two more? No? Okay. So this is we finish our presentation. So here, let me share my screen. Okay. I will show the results and answers to your very share. Suddenly disappeared from my screen. Lauren, how can wait? Oh yeah, I got it. What is it? Yeah. Share. Can you see my screen now, guys? Yeah, what's the primary
Yes.
objectives? Yeah, fantastic, thank you. Provide quality care, all of you, right? Boom. So like this, just have a look. What is following is direct cost medical supplies? 4 of you are right, 1 wrong. That I did not include. What is the key reason for the rise in healthcare cost? Technology, 4 of you are right. And 1 wrong. That doesn't matter, don't have to worry. So 5, all of you 5 given, and the right one is outsourcing admin cost. A function expanding service line will add more cost, guys. To control, you can't control. If you add a service line, it will be more cost, isn't it? So if you outsource a lot of things like call centers to trials, testing trials, this kind of medical equipment, reduce the supply chain. We'll discuss those things when you guys are in classroom. We'll have more time to do that. So another thing I wanted, a question is that which is not considered source of, that is investment in external companies. 3 right, 1 wrong. And the overall, you've done fantastic, all of you, without any immediate, without any means health and finance combination studies. So we are going to do that. It's finance, as you know, like the MIT professor was saying. It's not just in capital market. It's been existing for over hundreds of years in capital market. The CDS, CDS, credit default swap, option pricing, binomial models, high volume trading. It's all there. Bonds, securities, index, over the counter traded funds, OTCs funds. So it's a lot there. But how technically we can take them and apply them within the system. I'll conclude the presentation with an example You all know MRI scan, people for the internal scan. We all know MRI scan, medical resonance imaging. Do you know that was never developed for healthcare? It was developed by USA Army, means military, to scan the things not visible to our eyes. And some people thought, why can't we apply that in healthcare? And that revolutionized the cancer, particularly chemotherapy treatment, because of early detection at cellular levels to know how much the cancer cells have mutated. So those kind of things, when came to market, is not the same thing. So for example, you will think of how can I take high volume trading or binary trading. It says, don't worry about the wordings now. You'll learn that in time. Or if you know it's good, can apply to the healthcare sector to elevate the stock price, to increase the value to stakeholders. Okay, some people have already started thinking of that. They have issued green bonds. That means any proceeds come from that bond should go for welfare, for environment. We have also health bonds. We have currently working in a paper on green bond, not working, actually submitted. We finished that few weeks ago, submitted. We seeing into how the companies are issuing green bonds. So you can do your project, research project, similar topic, what kind of health bonds are there, how they can add value to collective welfare. Can they bring social equity or healthcare equity? If so, what are the channels? Some very interesting topic to study, and I hope I will see you guys soon in 2 months' time in classroom. And I'll stop here and pass it on to Lauren. There are a few slides. Lauren, do you want me to put it on again?
Yes, please.
Okay, sorry. Here's my.
That's okay.
Yeah, for some reason, is this one? What is it?
If anyone does have any questions
Yeah.
for Rama, please just pop them in the Q&A box now. We've got a few minutes before the end of the session.
It's Lauren yours.
Perfect. Thank you. So yes, most of our attendees today will be offer holders, but just so you're aware, our applications close for those who require a visa on the 27th of June, so not very far away now at all. And if you don't require a visa, they close on the 29th of August. If you have an offer, you have 5 weeks from your offer to accept. And we have a number of scholarships, and specifically GBSH scholarships. And the deadline to apply for those is 29th of June. So again, not very far away. We have a Global Healthcare Leaders Scholarship and a Women Healthcare Leaders Scholarship applicable to our master's degrees. I'm just going to pop the link in the chat now because we would encourage you to apply as soon as possible. And then if we just go to the final slide, please, Rama. Great. So we're offering one-to-one appointments. So if you would like to speak to Rama for on a one-to-one basis for a 15-minute appointment online, then please book in. You can also speak to Shayla, who's the program lead for Global Healthcare Management for all routes. There's a QR code on the screen now that you can scan, or I'll put the link in the chat. And then just to say to keep in touch with us and everything that's going on at the Global Business School for Health, please follow us on our social media, particularly on LinkedIn. You'll see a lot of what's going on in our department, conferences we're attending, news, scholarship announcements, everything is on there. So we'd really encourage you to engage with us on LinkedIn. Yeah, we've got a couple of minutes. So if there are any questions, we'll just stick around just for a few minutes in case you'd like to ask one. So do pop that in the Q&A box on your screen.
Another thing, you can have the slides. I did the presentation today. And if you don't have a question now, don't feel that you don't have an opportunity. You can always email me or Lauren directly and copy to me. And so if anything comes up later to your mind, okay, or this is the question I should have asked, you can always email us directly asking the question. We'll be happy to answer that, or we can have one-to-one meeting with us.
I've just popped our email address in the chat as well. So yes, if you have any questions that you think of after the lecture today, do email contact@gbsh.ucl.ac.uk and we can get that to the right person to answer it for you. I think we'll just stick around for maybe 2 more minutes to see if there's any questions.
Think of any question, good questions, okay? So don't worry about the learning and teaching platform. We have a highly IT supported, technology backed virtual learning platforms. You might have done before, like Moodle, eViews. What views? The virtual learning we use is Moodle. You can find most of your learning and teaching materials on Moodle. That includes your slides, videos, reading list, quiz, additional journal papers, industry reports, link to various activities, on additional recommendation for reading. That helps you to write reports, assignments for exam and for your research report, business report. So virtual learning environment is one of stop where you can see a lot of materials together. And then again, you have the opportunity to discuss each week's materials in details with further critical views, further critical reflection in classroom. Then you are supported with seminars. So seminars will be in different groups, not the large class together, small groups. Small means 30 students, 25, 30 students. So you can have a case study and activities, a report. So you do that, you interact with your classmates, your mates, your peers, your seminar tutor, seminar teacher, and that's quite interactive. That's very helpful in terms of building a practical hands-on experience learning. For example, there was a big deficit in King's College. You might know King's College Hospital. The half a billion deficit in 2020. So the government bailed them out because they're too big to fail. There is a saying in finance, too big to fail. It's so big, they don't fail. So if they fail, the entire system, which we call systemic, which you have seen during financial crisis, will be affected. So somehow government and people try to rally around that and support that. Okay. So these are the things you can see on your virtual Moodle, a lot of materials there. There's more than plenty to get you prepared for anything. In addition to that, we have guest lecture, additional sessions for qualitative, quantitative, statistical analysis. Then we have industry experience going out. You have different visits. So your entire year will be fully packed in a very constructive, positive, and enjoyable experience. Okay. And do you have any question? You don't have.
There's one question
Oh,
actually. It says, does the curriculum include hands-on training and using tools like cost-effective analysis, etc., to
yes.
guide real-time health policy hospital decisions?
Real hospital data? Not really. We have a module run by Sunila, Dr. Sunila Tomini. She runs the health evaluation. So she uses data, probably not real hospital data, but data which will be enough to explain the cost effectiveness impact, why it is used, how it is used. For example, I use also similar data to show you how risk could be captured, what kind of risk we're capturing, and what is the tool. Like I told you, Cox proportion hazard model, we'll apply that. It's a hazard model, but for anything, flood to climate disaster to financial crisis to health crisis, unemployment, fire, you can apply that. So it's based on probabilistic distribution of event. So yes, we do sometimes, but getting hospital data is not easy in UK because it's highly protected to collect the patient data. So if you're collecting any data even from NHS, it's very complicated. So we won't have always patient level data, but we can have country level data. For example, we can take data from different countries, from World Health Organization, International Financial Fund, International Monetary Fund, and put them together to run our statistics or evaluation. Okay.
Okay, I think
Any other
that's all of
question?
our questions. So I think we might leave it there. Thank you so much, Rama, for your
Okay.
lecture
Thank
today.
you.
Thank you to our attendees. We hope you have a lovely the rest of your day or evening, and we look forward to seeing you very soon.
Yeah.
All right. Thanks so
Guys,
much.
bye. Thanks
Thanks.
for me.
Bye.
Bye.